Hi. I want to continue our discussion that we were having in class regarding psychological disorders. And so we had left off talking about anxiety disorders, and we had talked about generalized anxiety, GAD. We had talked about PTSD. We had talked about OCD, and we had talked about phobias. So I want to continue on. And if you follow along in your textbook, the next section is on depressive disorders and bipolar disorders. And it divides them into different categories. So major depressive order is probably one of the things that people are most common with. And if you look on page 551 in your textbook, it lists a variety of symptoms, emotional symptoms, behavioral symptoms, cognitive, and as well as physical symptoms. So you can see that on the top of page 151. But basically, when you're talking about major depressive disorder, you are talking about a feeling of hopelessness or a feeling of helplessness that permeates one's entire life. Remember, it has to be maladaptive. So it's not just one exposure to depression or even a couple, but it's something that is extensive. And if it's major depressive disorder, it's chronic and pervasive. And so there are other types of mood disorders as well. Seasonal affective disorder usually occurs for individuals in winter months. It has to do with the amount of light and vitamin D that individuals get. And so people that live in climates with less access to light during the winter months are more prone to seasonal affective disorder. But it affects your mood. So you might feel more unmotivated to do things. You might feel a little bit more depressed. You might have more negative mood and emotion. Bipolar disorder also used to be called manic depressive disorder. And so that's an instance where individuals are swinging in their mood from depression or at a very low to being manic at a very high. So there's sort of an up and down to their mood swings. And sometimes they cycle, we call it cycle very fast. Sometimes they cycle slower, where it takes weeks or months to cycle from one to the next. But as most people's moods are relatively stable. They go up and down, but they're relatively stable. Someone with bipolar would go way up and then way down, and then way up and then way down, to have characteristics of things like major depressive disorder or mania. And when someone is manic, they are on such a high that sometimes they think that they're higher than life, greater than life, and maybe engaging in risky behaviors. They don't sleep much. They're literally going fast in everything that they do. So usually the best and the most effective treatment for that is a form of chemotherapy or drug therapy called lithium. Lithium really stabilizes people, so it takes them from those highs and lows to more of an even keel up and down. Unfortunately, it's hard to keep people with bipolar disorder on their medications because it does take away those really high highs, which feel good to them. And they will say that it makes them feel flat. So sometimes they stop taking their medication because of that. The next section talks a little bit about eating disorders, and I'm not necessarily going to get into anorexia or bulimia. If you're interested in that, though, feel free to view that in your textbook. I want to move a little bit to personality disorders. And so on page 563, at the top of page 563, you can see some descriptions of different kinds of personality disorders. I'm not necessarily going to go through all of them, but you should know the symptoms that are associated with antisocial personality disorder. And that's what, when people refer to psychopaths or sociopaths, that's what they're referring to. Borderline personality disorder, narcissistic personality disorder. So just be familiar with those kinds of things. So when you're talking about a personality disorder, really you're talking about an individual that has personality traits that are inflexible, and remember, they're maladaptive. Excuse me. If I didn't say borderline personality disorder, make sure that you're understanding that one as well. Also, let's add to that dissociative disorders. And dissociative disorders, maybe we should have talked about when we talked about anxiety, because they are anxiety-based. And so usually remember when we talked about defense mechanisms, there's sort of a way to protect oneself. When there's a traumatic or a threatening event, sometimes individuals will dissociate from reality. So they're having sort of a break. And the three most common are dissociative amnesia, dissociative fugue, and dissociative identity disorder. So in dissociative amnesia, it's sort of a loss of memory of something traumatic that has happened. And so they might have a traumatic event or a stressful event, and then they don't remember it. Sometimes they don't even remember their name or where they're from or anything important about their life in that threatening situation. This is a little bit different than amnesia that would be caused because you had a brain injury. This is amnesia that is caused by the effects of stress and anxiety. A dissociative fugue is a flee from a normal situation. So it's individuals that, again, because of threat or fear, would leave their current situation. In some cases, they leave their city or their town or even their state, and they might show up in another state, and they take on a new identity and a new job or whatever else it might be. And so that's called a dissociative fugue. The one that people probably are most familiar with, but they don't really realize what it's called, dissociative identity disorder. Sometimes people call it multiple personality disorder, or they call it split personalities, is a form of an anxiety disorder as well. And remember, when people are faced with threat or fear or some kind of stressful situation, they're dissociating. And in dissociative identity disorder, they actually take on alters. So they take on multiple personalities. They don't just have one, but they have multiple personalities. And I encourage you to do YouTube. And when you get to YouTube, type in something like Tony DID. There should be a video on there from Worth Publishers that maybe is only about 3 or 4 minutes long, but it will show you or give you examples of this man named Tony that had, I think, 27 different personalities. And each one of those personalities sort of takes over a different part of Tony's life and is able to, really what they're doing is compartmentalizing one entire being into several different personalities. And the personalities can be very different from one another. They don't have to be, you know, if let's say Tony's a 57-year-old black male, the personalities or the alters could be anything. Could be a 5-year-old white little girl, or could be a 60-year-old Native American woman. They don't have to be necessarily the same gender or sex or age that the person is. So it's quite interesting, but I would encourage you to do some YouTube searching to sort of understand. I think there might be a video in the learning plan on dissociative identity disorder as well, so give you some more clues as to what that's all about. It's important to realize that dissociative identity disorder and schizophrenia are not the same thing. So dissociative identity disorder has to do with one's ability to dissociate, to compartmentalize, and it's in a response to stress or anxiety. Schizophrenia is a psychosis, which means that the individual is having a break between thought and reality. So schizophrenics don't have multiple personalities, but they do suffer from things like hallucinations or delusions, and those hallucinations could be visual, they could be auditory, they could be olfactory hallucinations, but also they might suffer from delusions, maybe delusions of grandeur, where everything is bigger than life, and they take on these big notions that they're going to do great things, maybe be someone famous, or just have unrealistic ideas of what they are going to be and what they are going to do. A delusion of persecution, they might think that everyone is out to get them, right? They might be paranoid. Probably the most common form of schizophrenia is paranoid schizophrenia, where they are constantly worried that someone is out to get them. And so that's not the only kind of schizophrenia. You could also have a catatonic schizophrenia, which instead of hearing multiple voices and seeing things and those kinds of things, which would be typical symptoms of schizophrenia, they might be catatonic, where they're mute and they aren't moving at all and they're not talking at all. Not that you can't move them. You can move their hands and arms, but they aren't moving their hands and arms. So they're in a catatonic, mute kind of state. So there's negative and there's positive symptoms to schizophrenia, and I encourage you to look at that on page 571. For the next couple of pages after that, it talks about the prevalence rates of schizophrenia, and we already talked about the fact that we believe that there are genetic inheritability traits to schizophrenia. So for instance, if you were to have schizophrenia and you had an identical twin, that identical twin would be 50% likely to also have schizophrenia. So the closer you are in relation to a person, of course, the higher the prevalence rate you would have for schizophrenia. The farther you go out genetically, the less likely you would have schizophrenia. And so just make sure that you're taking a look at some of those things. And my plan is to talk about some treatments on Thursday and then to take exam 4. So make sure that you're looking at the page numbers that I gave or in class or that I put on the announcement section so that you know that what you're looking at. Use your study guides to know what's important in the chapters. And exam 4 is going to be 25 multiple choice questions, each worth 1 point. And then there will be an extra credit short answer question worth 2 points so that you have a chance to earn a few extra points on that last exam. So I will check my email intermittently over the next few days. If you have questions, make sure that you ask. Or if not, I will see you on Thursday, April 6th for our last class. Okay, bye-bye.